Yalimadet. My name is Dr. Sherin Kassamali. I'm an emergency physician and head of the Accident and Emergency Department at Aga Khan Hospital, Dar es Salaam. I'm also a member of the Aga Khan Health Board, Tanzania. Welcome to today's program. I'll be your host for today. We're going to be talking about an important topic, cancer. Did you know that cancer is the second leading cause of global death? According to the World Health Organization, 1 in 6 people die from cancer. And in 2018, it's estimated that 9.6 million people died from cancer. Now, it's an important topic. We're familiar with it, but we really still need to learn from it. Learn about its causes, its risk factors, and prevention. Today with me, I have health experts in this content. Dr. Aleesha Adatia and Dr. Harrison Chuwa, both my colleagues and working at the Aga Khan Hospital, Dar es Salaam, Tanzania. We'll begin with Dr. Aleesha Adatia. She will be speaking to us about breast cancer and cervical cancer. Dr. Aleesha Adatia specializes in palliative care, cancer pain management, chemotherapy, and radiation therapy. She has a Master's of Medicine in Clinical Oncology from Muhimbili University of Health and Allied Sciences. With that, let's welcome Dr. Aleesha Adatia.
Thank you so much, Dr. Sherin, for having us here.
Thank you. So let's start with breast cancer. What is breast cancer and what's the prevalence of breast cancer globally?
When you have a malignant transformation in breast cells, that would actually cause breast cancer. Breast cancer is one of the most common cancer affecting women globally. In fact, according to the data you presented of 2018, breast cancer was ranked the first most common cancer globally.
Okay. Does it affect men too?
Yes, breast cancer affects women more compared to men. It affects both genders.
And what are the risk factors for breast cancer?
Risk factors vary from women to women. Risk factors are categorized as non-modifiable risk factors, the ones that you cannot change, and modifiable risk factors, the ones that you can change. The non-modifiable risk factors are gender. You are more likely to get breast cancer if you're a woman. Age. Your risks of getting breast cancer increases with age. Genetic composition and family history. And personal factors such as early initiation of your menstrual periods before the age of 12 and going through late menopause after the age of 55 years.
Oh, okay.
The modifiable risk factors are prolonged use of hormone replacement therapy, prolonged use of oral contraceptive pills, having a first child after the age of 35 years, or not having a child at all, and not breastfeeding. These are the modifiable risk factors.
Okay. And what are the symptoms of breast cancer?
Symptoms may vary again from woman to woman. They are not specific and they are not limited to. So first one would be maybe a painless lump on the breast or around the axilla. You should look for changes in the size, contour, and the symmetry of the breast. You should look for the change in the size, color, symmetry of the nipple, and also look for nipple discharge. You should look for a change in the skin around the breast. You should look for dimpling, puckering, thickening, or even scaling around the breast. Sometimes you may also have a painless lump around the collarbone and around the axilla as well.
Okay. And how can women and men pick these up or these signs earlier?
I love this question because there are a couple of things that I would like to emphasize. Is first that every woman and men need to know their risk factors. Secondly, you need to follow a committed screening guideline. Thirdly is we should be doing our monthly self-breast examination. The other one is annual clinical breast examination. That is usually done by your local GP or your oncologist. And then this can be accompanied by a mammogram or a sonography as well.
Oh, thank you for that. That brings me to our next question. How would you do a self-breast examination?
This is so easy to do. You actually do this at the comfort of your own house, and it usually takes around 5 minutes. There are 2 ways to do it. Firstly, by looking at yourself in the mirror or by laying down flat. If you choose to look at yourself in the mirror, make sure both your hands are placed on your hips. And if you decide to do it while laying down, make sure the breast that you are examining, the hand on the similar side is actually on top of your head. The first thing you would do is look at the appearance of it again, the size, the symmetry, the contour, any color changes, and note for any changes that you see. The second step is palpation. What you would do here is you would use the fingertips of your 3 fingers, and you can start in circular motions from the outward moving inward, making sure you do not miss a patch of the breast tissue when you are palpating. You do the similar steps for the nipple as well. Once you reach the nipple, gently squeeze your nipple with your index finger and thumb and observe for any nipple discharge. You complete your examination via palpating through in between your breasts, your collarbone, and your axilla. Repeat the similar steps on the next breast and report for any changes to your local GP or oncologist. A self-breast exam is best done 5 to 7 days after your menstrual period because at this time your breasts are less tender.
So this can be done monthly?
Correct. This is to be done monthly.
Okay, and my other question was, what is a mammogram? And is it painful to do one?
A mammogram is a low-dose X-ray modality that usually views and detects any breast anomalies. A mammogram is recommended for women above the age of 45 years. A mammogram is to be done annually by every woman for as long as they are in good health. Some women are recommended to do mammograms every 2 yearly, but this needs to be discussed and managed with your local GP and your oncologist. Back in the days, mammogram may have been painful. I do not have an experience back in the days, but with the new medical era and the new machinery, we actually have a patient compression control, meaning that it is not painful. It will be uncomfortable for a couple of seconds, but it is not painful at all.
I'm sure viewers would like to hear that and are happy to hear that it's not painful now, right? So next, I would like to ask, there's a lot of myths going out in social media about breast cancer, and I'll ask you, and you can debunk this or you can agree with this. If I don't have a family history of breast cancer, I won't get it.
This is a myth because only 5 to 10% of breast cancer cases have a history of breast cancer. This means that 90 to 95% of breast cancer cases are actually attributable to environmental and lifestyle behaviors.
Okay. If I maintain a healthy weight, exercise, eat healthy, and limit alcohol intake, I don't have to worry about breast cancer.
That again is a myth. These things can reduce your risk of getting breast cancer, but it will not eliminate it.
So are modifiable risks.
Correct.
Okay. Using underarm antiperspirant or deodorant can cause breast cancer.
That is a very common myth that we see a lot of it on the internet. There is no evidence or there is no strong evidence that proves that the use of antiperspirant can cause breast cancer. In fact, antiperspirants can cause itchiness or redness around the skin, but there has been no direct link between the usage of it and breast cancer.
Okay. All breast cancers are treated pretty much the same way.
All right, now this is another myth that I would like to talk about. Breast cancer has a variety of treatment, and treatment varies from the characteristics of breast cancer, the person's preferences, and the patient's quality of life. A patient's treatment can fall under surgical therapies and either surgery or breast conserving therapy. It can either be chemotherapy, immunotherapy, or hormone therapy, or even radiation therapy. However, characteristics such as the stage of the cancer, the grade of the cancer, the immunohistochemistry receptors, the oncotype DX result, all of it actually play an important role in management of the treatment of breast cancer. Therefore, breast cancer for every woman is tailored upon all the characteristics I mentioned, and most importantly, their preference and their quality of life.
Okay. And breast cancer can only happen to middle ages and older women.
That again is a myth. We have now seen that breast cancer is also common in younger women, same as younger men as well.
Okay. Wearing a bra can cause breast cancer.
This is another myth that's going on a lot on the internet, that wearing a bra will cause breast cancer. Again, there is no strong evidence that suggests wearing a bra is going to give you breast cancer. In fact, a study in 2014 roughly took around 1,500 women with breast cancer, which showed no link between wearing a bra and breast cancer. You know, the theory was that if you wear a bra, you actually accumulate all the lymph fluid, and then there's toxins around the breast, and that would actually cause breast cancer. But that has no evidence. There are several studies still ongoing about wearing a tighter bra, and we will keep an eye on that.
That's another good news for our viewers as well. If a woman is pregnant, she can't get breast cancer.
That is a myth. Although it is rare for a pregnant woman to be diagnosed with breast cancer, but this is a possibility. Pregnancy does not cause breast cancer. What happens is that if you have a tumor or a malignancy during your pregnancy, the tumor may tend to grow a little bit faster due to the hormonal changes the pregnant woman is facing. So pregnancy does not cause breast cancer.
Okay. A mammogram can cause breast cancer to spread.
Now, this is actually one of the myths that I get in the office as well, because if I want to diagnose and they have a lump, and they would say that statement. It is important to know that mammogram up until now is the gold standard of detecting breast cancer at early detection. All right? Breast compression does not cause the spread of breast cancer. In fact, according to the National Cancer Institute, the benefits of doing a mammogram outweighs the radiation exposure, because a mammogram uses very small radiation doses.
And you mentioned it earlier that mammograms can be done annually. Does it mean that yearly, every year, once every year, or suggested by a specialist like yourself? Okay. Breast cancer is contagious.
That is not correct. You cannot transfer breast cancer from one person to the other. You can, however, reduce your risk by living a healthy lifestyle, and by getting screened, by following the screening guidelines.
Thank you. So what advice would you give to men and women out there watching today on breast cancer?
What I would tell men and women today is acknowledge breast cancer. It is there, it's real. Know your risk factors, know your family history, have a healthy weight, feed your breasts healthy. So a low-fat diet and a diet high in vegetables and fruits and leaner meat is actually optimum for breast health. Exercise regularly, avoid alcohol consumption, and stick to your screening guidelines, and there is nothing to be scared of.
Thank you. So we'll move on to the next cancer, and that's cervical cancer. This is less common than the breast cancer that people talk about and know about. So let's talk about cervical cancer. What is it, and how common is it?
All right. The cervix is actually located at the lower end of the uterus. It is the same tissue that dilates or widens at childbirth, and it is the same tissue that assists in the menstrual flow between the uterus and the vagina. The cervix is actually a fibromuscular tissue, and it is cylindrical in shape. So when cervical cells have a malignant transformation, that is actually cervical cancer. According to the similar data that you and I presented earlier, cervical cancer ranks the 4th most common cancer globally.
Mm-hmm. Okay, thank you. And what are the risk factors for getting cervical cancer? And can you tell us a little bit about HPV, or human papillomavirus?
Correct. HPV is the human papillomavirus. It is a virus. There are 200 types of viruses. From that, 13 of them are high risk, the rest are low risk. 90%, or I can say more than 90% of cervical cancer is caused by the human papillomavirus. So when I talk about risk factors, categorize it as HPV related and non-HPV related. The HPV related would be early onset of sexual activity, multiple sexual partners, immunosuppression states such as cancers, or immunocompromised states such as the HIV infection. The non-HPV related risk factors would be low socioeconomic statuses, cigarette smoking, and genetics.
Okay. And does cervical cancer have any symptoms, and what would they be?
All right. Cervical cancer can have no symptom at all or can have as vague symptoms such as a backache. However, some alarming symptoms could be pain during sexual intercourse, abnormal vaginal bleeding. This is when you may bleed during or after sexual activity, abnormal bleeding between your menstrual period, and an even alarming sign is bleeding after menopause. That would actually indicate a pelvic malignancy. Abnormal vaginal discharge, and non-specific symptoms such as weight loss and fatigue and backache and pelvic ache.
Okay. And what is a pap smear test? And when does one need one?
All right. A pap smear test is a very important test, also known as the papillonococcal test, is actually the sampling of cervical cells that will be closely examined in the laboratory. What happens with a pap test is that you need to follow the screening guidelines very effectively. And these are as follows. Under the age of 21 years, you do not need to have a pap test. At the age of 21 years, no matter your sexual activity, you need to begin having a pap test. Between the ages of 21 and 29, you need to have a pap test every 3 years. Between the ages of 30 and 65, you need to have the pap test every 3 years, and this can be combined with HPV DNA testing every 5 years. It is very important to note that women who are immunocompromised or immunosuppressed, or the ones who have abnormal pap tests, will have frequent screening compared to the screening guidelines I have mentioned.
Okay, so we both fit in that age group for getting pap smear screening.
Have you gotten a pap test done?
Yeah, I have actually.
Good job, Dr. Sherin. So there are a couple of women actually who are not fit for getting a pap test. Those women are women who have undergone a total abdominal hysterectomy.
Okay.
Women obviously under the age of 21. All right?
So total abdominal hysterectomy would mean the removal of the uterus and the cervix.
Correct. All right? And women under the age of 21, obviously.
Okay.
Women who get vaccinated with the human papillomavirus should continue screening guidelines as per what I have mentioned.
Okay.
All right? For women who have had their cervix removed due to a malignancy, should also have their screening done as the guideline I have mentioned. And as you mentioned, it is so important for women to understand the difference between total abdominal hysterectomy and subtotal, because as long as you have a cervix, you need to get screened.
So how would you prepare for a pap test?
This is a very important question because a lot of women come to the hospital and return back home very disappointed. But when you book for a pap test, you should not be in your menstrual period. You should avoid using vaginal creams, foams, or jellies 2 to 3 days before your pap test. You should also avoid vaginal intercourse 2 to 3 days before your pap test. Pap test is very simple, it is painless, and it's actually a 5-minute procedure that is done in the outpatient basis in your doctor's office.
Thank you. So with regards to HPV, let's also debunk some of the myths that are out there, okay? All HPVs cause cancer.
That is a myth. Not all HPVs cause cancer. Most of them are low risk and they would cause genital warts.
Okay. If I have protected sex, I'm not at risk of getting HPV.
That is a myth again, because protective sex will actually reduce your chances of getting an HPV infection. You see, HPV lies around the pelvis. So in men, you would find the virus in the scrotum, the anus, and the rectum. And for women, you would find it in the vulva, the vaginal wall, the cervix, and the rectum. So protected sex only protects that area, but HPV is actually spread from skin to skin contact.
Okay. Can HPV be treated?
Good thing about HPV is that it is self-limiting and it would get over on its own, it would clear out on its own. There is no direct treatment for HPV, but there is treatment for associated HPV effects such as warts, dysplasia, and cervical cancer.
Can we get checked for HPV?
Correct. You can get checked for HPV by using the HPV DNA test, and it is recommended to start at the age of 30 years.
Okay. Are HPV vaccines available?
Yes, HPV vaccines are available. They're available globally, Both girls and boys are supposed to get this vaccination. You can start vaccinating your children as early at the age of 9 years.
Oh, wow. Is HPV vaccine safe?
It is safe. It works. It is given to both boys and girls. It has no fertility, it does not cause any fertility issues, and it has not known to cause any serious side effects.
And how many shots are there?
So it depends. It can vary from 2 shots to 3 shots depending on the age you begin.
Okay, thank you. Cervical cancer cannot be prevented.
This is a very personal question to me because I believe cervical cancer is a preventable tragedy. Apart from a pap test, you can also get a VIA, which is visual inspection via acetic acid, or VILI, which is a visual inspection via glucose iodine, which is so easy and cheap and probably done in every center possible. It just depends on us to get that done because this app can actually detect cancer cells even before the progression of cervical cancer.
Okay. Actually, I as a general doctor, I used to do that as screening processes in mass screening at Sabasaba grounds for women in Tanzania. So I used to do that for breast cancer and cervical cancer. Any final advice for women?
Yes. I know it's difficult to figure out why one woman or why one person has cancer and why the other one doesn't. But it is so important to take note of your risk factors. There are a lot of articles on the internet, especially the ones that says everything causes cancer, which is such a popular hyperbole right now. And if you find yourself in that parade of confusing articles that give you anxiety, what I would tell you is seek professional advice. Seek advice from your GP and oncologist rather than relying on non-evidence-based articles that flow around social media, WhatsApp and Facebook and everywhere. Life as we know it is a gift. Screening, on the other hand, is a smart and an intelligent choice. The choice is yours. The future is ours. Get screened and stay safe.
Thank you so much, Dr. Aleesha, for that insightful information. And I couldn't have mentioned it or said it better myself. Just as a recap, know your risk factors and know your screening and screen early to detect and prevent cancer. Thank you. Now moving on to Dr. Harrison Chuwa, who will be discussing about prostate cancer. Dr. Harrison is a consultant clinical oncologist and the head of oncology department at Aga Khan Hospital, Dar es Salaam, Tanzania. He is also the project director for Tanzania Comprehensive Cancer Project, which aims to strengthen and expand the quality of access and the capacity of cancer care services through an innovative public-private partnership initiative. Thank you, Dr. Harrison Chuwa, and welcome.
Thank you, Dr. Sherin.
So we'll start right away, and I'll start with what exactly is prostate cancer?
I'd like to start what is the prostate, and then later on I'll explain what is prostate cancer. So the prostate is a gland that is found in the male reproductive system, and it's very small. It's like the size of a walnut, and it's found between the urinary bladder, which is on top of it, and the rectum, which is below the gland. Prostate cancer is the transformation of the normal prostate cells. They transform and they become cancerous. When we say it becomes cancerous, it means that those cells lose its ability to control its reproduction, so they get out of control. They replicate and reproduce so rapidly, and they also lose the capacity of dying, so they become immortal. So by them being immortal, it means it piles up, forming a tumor, a mass, a tumor, and all the symptoms associated with the disease. Now to become cancerous, it means those cells now have the capacity of moving from that gland and going to affect another part of the body. That's what we call prostate cancer.
Okay, thank you. And what causes prostate cancer?
So until date, this is 2020, we are not yet certain of a cause. We've not yet identified a cause. But what we know is there are associated risk factors.
Okay.
And then, like like breast cancer, these risk factors can also be categorized like modifiable and non-modifiable. For instance, age is a risk factor. As we age, as men age, the prostate gland also grows, and by it growing, it can now lose its ability to control the rate of growth and become cancerous. We also know race plays a role. Men of African descent are more likely, and by percentage is 60% more likely to get prostate cancer compared to Caucasians and other race. So race plays a role. And then there's also genetics or family history. With those with positive family history tend to have high risk of getting prostate cancer compared to those with no family history. So these are some few of the non-modifiable risk factors. And when I say also genetics, we know that there's a gene called BRCA1 and BRCA2. These are also for breast cancer, but men with BRCA1 and BRCA2 genes are also at risk of getting prostate cancer.
Okay.
For modifiable risk factors, they include lifestyle modifications, like obesity, a sedentary lifestyle. All these contribute to risk of prostate cancer. Not forgetting tobacco use, which includes both tobacco chewing, sniffing, and smoking,
Okay.
and alcohol use.
Okay. So we've already established that this is more in male because of the prostate gland is in males.
Yeah, so basically it's not more in male, it's exclusively
Thank
in
you.
male.
Thank you. What are the common signs and symptoms of prostate cancer?
Yes, so normally early stages, they usually don't have any symptoms. Symptoms start showing up as the gland gets enlarged, bigger and bigger, and the symptoms are more associated with urinary symptoms. A few examples, the failure to urinate, or you're getting difficult, the male gets difficulty in urinating, initiating urination. The urine stream becomes less, usually it was longer, but now it's less. Waking up at night frequently to go to urinate. These are all some of the risk factors.
Signs and symptoms.
Including incontinence.
Okay.
Yeah.
And it makes sense because you have just elaborated of the position of where this prostate gland is.
Yes.
And when should one test for prostate cancer, and how is it tested?
Yes, it's a very good question. So as I mentioned, for those with positive history, the age for testing is recommended at 45.
Okay.
And then these include those with the gene, those with family history of prostate cancer, and those of African descent. So those are usually advised to start testing, screening or testing for prostate cancer at the age of 45.
Okay.
For those that have no family history or don't carry any of those risk factors, usually they are recommended to start testing at 50 years and above. And the test normally that is done is usually a PSA test. PSA stands for prostate specific antigen,
Okay.
which involves taking blood sample for that, and then we test. And also a digital rectal examination that is done by your physician in the bedside during your consultation.
So a physical exam.
Yes, together with the blood test.
Okay. And if one has prostate cancer, should they see a urologist or an oncologist?
It's a very good question that you've raised, and I think in our setting, patients do get confused. Where do they go? What should they do? So a urologist is a surgeon, but is specialized more on the male urinary system together with the reproductive system, while an oncologist can be divided into 3 subspecialties. There is what we call a radiation oncologist, who deals with radiotherapy. There's a medical oncologist who's responsible on chemotherapy and hormonal therapy. And there's also what we call a surgical oncologist. Now, for instance, I and my colleague, Dr. Aleesha, we are clinical oncologists. It's a combination of radiation together with medical oncology. Now, when we have such patients, depending on the symptoms, we should know that cancer treatment is a multidisciplinary approach.
Mm-hmm.
It's not a one-man show. It's a team show. I, as an oncologist alone, cannot treat the patient. Neither can the urologist. So, if the symptoms are more related to obstruction, so it's more of the urologist. And if the symptoms are more, or if it's more on how to treat and manage the prostate cancer, then the oncologist. A good way of putting it, so that a good analogy, it's a fun that I make to the urologist is, urologists are like plumbers. Yes. So they take care of the plumbing system. So they make sure that all the pipings and everything flows well. And once they're done, they hand over to the oncologist, whereby now we make sure that the both cells safely throughout the patient's life. Yes.
Thank you. And we mean by obstruction of urinary floor. Okay.
Floor, yes.
And what are the potential side effects of prostate cancer treatment?
Yes, so it all depends on the type of management that the patient receives. For instance, with surgery, either endoscopically, whereby they can do transurethral prostatectomy, or if they do open prostatectomy or laparoscopic or robotic, depending on which procedure. But if it's surgical,
Mm-hmm.
there is risk of having a sexual dysfunction.
Mm-hmm.
There is risk of having urinary incontinence, meaning you're not able to have bladder control, so you can just ease yourself without knowing. But if you are treated, for instance, with radiation, then, as I said, that's the prostate location. There is risk of radiating the bladder, urinary bladder, so you can get what we call radiation cystitis. So it's
Okay.
like inflammation of the urinary bladder. You can also get proctitis,
Mm-hmm.
meaning inflammation of the rectum,
Mm-hmm.
whereby someone can present with bleeding from the rectum and very painful pain coming from the bottom. So all these are complications because of the type of treatment.
Okay.
If the patient is receiving, let's say, chemotherapy, then it means there is hair loss, there's nausea, there's vomiting, there's hyperpigmentation darkening of the palms and so. So the side effects are all dependent on the
Treatment.
treatment. If it's hormonal, sorry, I'm talking too much.
That's okay.
'Cause
Go
it's my
ahead.
passion.
Go ahead,
So
please.
if it's hormonal, it may present with, for instance, for men, they can get what we call gynecomastia, meaning
Mhm.
enlarged breast
Tissue.
breast tissue. They can also have hot flashes.
Mm-hmm.
So it all depends on the type of treatment this patient is receiving.
Okay. And you mentioned a little bit about this, but when is surgery considered for prostate cancer?
Yes. So surgery is usually recommended at very early stages.
Mm-hmm.
And if I go more scientifically, it means it's anything between T1 and T2. So anything beyond that, surgery is usually not recommended. And as I mentioned earlier, 3 types of surgery. You can have the open, whereby you open up the whole abdomen and then remove the prostate gland, or you can do it laparoscopic,
Mm-hmm.
or you can do it by robotic.
Okay. And just for audiences to know better, what is T1 and T2?
Okay, so T1 refers to the size of the nodule. So if it's less than 2 centimeters, we call it T1. If that nodule is between 2 and 5 centimeters, we call it T2.
So it's with staging in early
Yes,
stages.
yes, so it's
Okay.
so it's for early stages.
Okay. And you've also mentioned this a little bit, but can prostate cancer be treated by radiation therapy? And when is this considered?
Yes, so prostate cancer can also be treated by radiation therapy, and it's also usually also recommended to do it at the early stages.
Okay.
The same with the like doing
Surgery?
surgery. But the only advantage with radiation is that the outcome for treating with radiation and surgery is more or less the same. Studies have been done and it has shown that if you do surgery and if you do radiation, the outcome is more or less the same. The only difference is that surgery is associated with more complications, so we say it's more morbidity compared to radiation, whereby less complications are involved. Yes.
So you could opt for treatment either or with similar results of that?
So ideally, a patient is supposed to be given these options and then given the pros and cons of each treatment modality, and allow the patient to make an informed decision.
Okay. Can prostate cancer be treated by chemotherapy?
Yes, it can be treated by chemotherapy, but unfortunately, most of the time, when we start considering chemotherapy, it means this patient has a very advanced disease and is not responding to hormonal therapy, whereby we refer to this as castration-resistant prostate cancer. That's when we will now use chemotherapy.
Okay. And what does the term active surveillance mean?
Yes. So there was a study done in Great Britain, whereby they were looking at the autopsies of elderly men living in this nursing home that have passed away. And what they come to find out is majority of them, although they died of natural causes, but had also prostate cancer. Meaning that prostate cancer, you can have it, it can be indolent without causing any complication, and you don't necessarily need to be treated for it. Okay, so with that, if someone is diagnosed with prostate cancer, there is a role of doing what we call active surveillance. Active surveillance is that you know that the patient is positive for prostate cancer, but when you do the test, we do histological examination, and we have a score, what we call Gleason score, and you find that the Gleason score is low, and when you look at the proportion of the tumor in that sample is also low. So there's a way of us saying that this is a low risk and a high risk patient. Once you categorize your patient as a low risk, then you can also just monitor the patient without giving any treatment, so that the patient can have a quality of life. Doing any treatment it means it will impair that patient's quality of life. But you have to be actively following up on the patient.
How frequent?
So there is a schedule. So we can do it either quarterly, meaning every 3 months, or semi-annually, every 6 months.
Okay.
So usually, at least for the first 2 years, you do it quarterly. Then thereafter that you are comfortable that if you do scans, that the size is not increasing. If you're looking at the gland itself, the capsule is still intact, patient is not experiencing any symptoms, then you are comfortable that I can continue just monitoring this patient. After 2 years, we can do it semi-annually.
Okay.
Yes.
And what is the role of hormone therapy, and how does it work?
Yes. So for an advanced prostate cancer, and here when we say advanced, it means it's already gone beyond the prostate gland and the nearby organs like the seminal vesicles and the vas deferens. It means it's gone beyond, it's encroaching the urinary bladder and encroaching the rectum below, or it's even spread to the bones, whereby now you cannot treat with radical intention or with curative intention. Hence, you're not supposed to give aggressive treatment. So you go with a treatment that will contain the disease, but with less complications or side effects to the patient. And therefore, we go with the hormonal one. And with that, the prostate cancer cells feed on the male hormone, testosterone. That's their food. So with hormonal manipulation, what we do is we block the production of this male hormone, testosterone. aiming at starving the cancer cells, the prostate cancer cells. That's the aim of it. Now, it's usually very successful, and there are two ways of doing it. You can do it by medical, it's all about castration, so you can do it medically or surgically. But we should know that after a long time, these cancer cells are also smart. They also find an alternative source of food, but it varies from patient to patient. Some patients takes 4 years, 5 years, some patients even 10 years, but some patients maybe within 6 months or 8 months, they become resistant to the hormonal manipulation. What I would like to advise the audience is that, number one, prostate cancer is real. There's a lot of myth in Africa that cancer is not real or prostate cancer is not real. Number one, it's real. Number two, it's treatable, it's preventable, and even if it's found at last stages, it can still be palliated, meaning there's also option for palliative care. For screening, we recommend that all men that are at high risk should start screening as early as 45 years of age. And for those that don't have high risk, at least at the age of 50, and they do screening at least once every 3 years. They come and screen, get themselves checked. And those with any urinary symptoms, don't ignore them. Even below the age of 45, it can happen. Just go see your urologist or see your oncologist, get checked. Prostate cancer can be treated. As I mentioned, all the expertise is available, all the treatment options are available, so you don't have to worry. Thank you.
Thank you very much for that, Dr. Harrison Chuwa. Again, it was a very insightful information, and I'd like to summarize by saying that prostate cancer is most common in male, and you can start screening as early as 45 years if you have high risk factors, or age of 50 if you don't have the high risk factors. And if you're diagnosed with prostate cancer, treatment is available. There's multiple options for it. So thank you very much.
Thank you, Dr. Sherin.
Once again, thank you Dr. Aleesha Adatia and Dr. Harrison Chuwa for such an insightful and informative session. I'd like to remind the audience that October is Breast Cancer Awareness Month. Use this time to raise awareness and get yourself screened. This program today was brought to you by the Aga Khan Hospital, Dar es Salaam, collaborating with the Aga Khan Health Board, Tanzania. Once again, thank you very much for watching. I'm Dr. Sherin Kassamali.